Hello, welcome to this talk on the basics of intracranial pressure waves. This is Mr. G. Narenthiran. The talk is in 3 parts. We will start with looking at the normal ICP waveform. Then we will proceed to look at the morphology of the ICP wavelet. And finally, we will look at pathological waveforms. Let's start with what factors contribute to the normal ICP waveform. I will take you through few hypothetical scenarios in order to clarify the contributions of various factors to the ICP trace. Let's drill this down from the base. What trace would we get if we monitored the ICP in a cadaver? Yes, it will be a straight line, a flat line. Now, imagine of a hypothetical patient who does not have any pulse but who still breathes. What type of ICP trace will be obtained in such a hypothetical patient? It will be a low amplitude, smooth, undulating wave corresponding to inspiration and expiration. The intrathoracic pressure would be transmitted through the venous system to the intracranial compartment, which will be reflected on the ICP tracing. Let's imagine another scenario. You have another patient, of course a hypothetical patient. This patient has heartbeats but no breathing. What would the ICP tracing in such a patient be? The tracing will look like this. Each wavelet will have 3 peaks. The peaks will be descending in height, and this wavelet will repeat with each heartbeat. This morphology is the main morphology of what we come to know the classical ICP tracing, and it is generated because of the pressure transmitted from the heart through the pulsation of cerebral vasculature. What ICP trace would we get in a patient who both breathes and has a pulse? We'll get a composite trace of the last 2 graphs that we saw. This base will be the undulating trace of the pattern which we saw that corresponds to the pressure transmitted from respiration, and this would be the superimposed trace on that respiratory trace of the pressure transmitted from the pulsating cerebral vasculature. So that's a composite waveform. There are additional influences to the final morphology of the normal ICP trace. These include the respiratory effect on blood pressure. There are subtle changes in blood pressure corresponding to the phase of respiration, and also blood pressure changes due to Traube-Hering reflex. This is the autonomic reflex that is mediated by mechano and chemoreceptors on the vasomotor tone that influences the blood pressure. These effects on the blood pressure is transmitted to the ICP trace through the degree of the pulsation of the cerebral vasculature. Now let's move on to the second part of this talk. It is on the components of the ICP wavelets. The normal ICP wavelet has three components. As we briefly saw earlier, there are three peaks. The first one is the percussion wave, also referred to as P1. The second one is the tidal wave, also referred to as P2. And the third wave is the Dicrotic wave, referred to as P3. We will examine each of them in turn. Before that, let's recap. These are the three peaks or three waves within the wavelet. The first one is the percussion wave, the second one is the tidal wave, and third one is the Dicrotic wave. They decrease in their height as we go from the first to the third wave. The percussion wave corresponds to the maximum pulse wave generated at the cardiac systole. The tidal wave is somewhat more interesting. We don't quite know the genesis of the tidal wave, this second peak. However, what we know is that this wave is related to the brain compliance, which we will look at in more detail on the next slide. So let's look at the tidal wave in more detail. In a tight brain with edema, contusion, hematoma, the compliance of the brain is low. What this means is that with a small increase in the intracranial volume, there would be large increase in the intracranial pressure. In such a low compliance state, the tidal wave would become more prominent, its height approaching that of the percussion wave. In some literature, they even mention the tidal wave being higher than the percussion wave. In a patient with head injury, if the tidal wave is prominent, then it is suggestive that the remaining reserve is diminished, and any small increase in volume can lead to marked increase in the intracranial pressure. Now let's look at the third wave, the lowest of the three waves, the Dicrotic wave. This wave corresponds to the Dicrotic notch of the aortic pulse wave. Why do we get Dicrotic wave in the ICP trace? We will look at this in more detail in the next few slides. As I mentioned in the last slide, we get the Dicrotic wave in the ICP trace because of the Dicrotic notch in the aortic pulse wave. So what we have to look at is to figure out why we get Dicrotic notch in the aortic pulse wave. This is a schematic diagram of the left lateral ventricle and aorta. This is the aortic valve and this is the pulmonary vein. We'll now move to the next slide. We will see what happens during systole. During systole, when the blood is ejected from the left lateral ventricle into the aorta, the blood not only propagates forwards, but it also distends the aortic wall. At the end of the systole, the aortic valve closes. The wall of the aorta recoils back This causes a small spike in the blood pressure that corresponds to the dicrotic notch, and that wave is transmitted intracranially through the blood vessels, which gives rise to the dicrotic wave in the ICP trace. Now that we have reviewed the morphology of a single ICP wavelet and its components, the percussion wave, the tidal wave, and the dicrotic wave, we will now move on to the third part of this talk, which is on the pathological ICP waveforms. It was Nils Lundberg from Sweden who had done the pioneering work on the ICP waveforms. The three waveforms that we are going to look at are eponymously named after him: the Lundberg A wave, Lundberg B wave, and the Lundberg C-wave. The Lundberg A wave is also known as Plateau wave. Lundberg B wave is also known as pulse wave or slow vasogenic wave. And the Lundberg C-wave is also known as Traube-Hering wave. The Lundberg A wave is definitely a pathological wave. Lundberg B wave can be seen in pathological conditions as well as in physiological scenario. Lundberg C is a physiological wave, but we will look at it more closely in the penultimate slide of this talk. So now let's move to look at the Lundberg A wave. So this is the schematic representation of a Lundberg A wave, as I mentioned in the previous slide, the Plateau wave. There are two important characteristics that you need to make note of. The first one is obvious, is the height of the wave. The height of the wave can be 50 to 100 millimeters of mercury. The second important characteristic that you have to note is the time scale. When we looked at the ICP wavelets that had that triple waves of P1, P2, and P3, they were less than 1 second long that occurred with every heartbeat or corresponding to every heartbeat. Whereas the Lundberg A wave can last anywhere from 5 to 20 minutes. The rise in the ICP is quite rapid, so is the fall. We will look at what might be the mechanism of this wave in the next slide. It is thought a vicious cycle of ICP, CPP, vasodilation, and cerebral blood flow underlies the genesis of Lundberg A wave. So when the ICP goes up, the CPP comes down, and when the CPP comes down, you get cerebral vasodilatation that causes increased blood flow to the brain, that increases the vascular component of the intracranial space. This increase in the vascular component causes increase in the ICP, which again in turn reduces the CPP, and this basically drives this vicious circle that is thought to lead to the high ICPs of the Lundberg A wave. As I mentioned in the last slide, the Lundberg A wave, then the pressure drops quite rapidly down. This is thought to be due to increase in blood pressure secondary to the Cushing reflex in response to the increased ICP, causing cerebral vasoconstriction decrease in cerebral blood flow and blood volume, then causing the decrease in ICP. So this is what's thought to be the cause for the rapid decrease in the ICP at the end of the plateau wave. In the current clinical practice, we usually don't see the Lundberg A wave. This is because patients are in the ICU and the ICP is monitored, and as soon as the pressure starts to climb up above the normal range, we start to institute measures to bring the intracranial pressure back. So we don't see Lundberg A wave in our clinical practice nowadays. Now let's look at the Lundberg B wave. It is more intriguing. As I mentioned earlier, it can occur in both pathological and physiological conditions. The most important aspect or characteristic of Lundberg B wave is its frequency. The frequency is 0.3 to 3 per minute. So if we take 0.3, that means that one wave every 3 minutes. And if you take the 3 per minute, then as it says, 3 waves per minute. So this is the most important characteristic of a Lundberg B wave. There are many classifications of Lundberg B wave depending on different characteristics. We will look at the Sine type and the Ramp type wave, as well as the low B wave versus the high B wave in the following slides. The Sine type B wave has a morphology that's very similar to the sine function wave that you would recall from your high school maths classes. This is an excerpt from the paper by Spielberg et al. That was published in the journal Interdisciplinary Neurosurgery, Advanced Techniques and Case Management, which shows the Sine type B wave. As you can see, it just undulates. In contrast, the morphology of the Ramp type B wave, also known as the sawtooth wave, has a different morphology. It increases fairly slowly and then has a rapid descent, increases and rapid descent, increases and rapid descent, similar to the sawtooth. This is something that you can see in this excerpt from the same paper from the journal Interdisciplinary Neurosurgery, Advanced Techniques and Case Management of the paper of Spielberg A et al. You can see this sawtooth pattern. It increases and a rapid descent. The Lundberg low and high B waves, they depend on the peak-to-peak amplitude. The peak-to-peak amplitude is the difference between the maximum and the minimum ICP values of the B wave. If the peak-to-peak amplitude is less than 10 millimeter mercury, it's called the Lundberg low B wave. If it is greater than 10 millimeters of mercury, then it's called the high B wave. The amplitude of B waves can be up to 30 millimeters of mercury, but usually the B waves are less in magnitude than the plateau waves. There is controversy on the mechanism that underlies the B waves. It's also thought to be related to vascular mechanism similar to that of plateau wave, but it's not well characterized. Now we are at the last of the Lundberg waves, which is the C-wave, also known as Traube-Hering wave. This is a low amplitude wave. The blood pressure is subtly regulated by autonomic reflexes that emanate from the chemo and mechanoreceptors. This is called Traube-Hering reflex, and this modulation of the blood pressure has a corresponding effect on the ICP trace, and this is the origin of the Lundberg C-wave. This low amplitude wave is a physiological wave. However, it can be seen superimposed upon Plateau wave, and in those circumstances the condition is often terminal. Let's recap. So in the first part we looked at the components that make up the normal ICP waveform. We examined the various contributions from respiration, from the pressure pulse transmitted from the cerebral vasculature, and the changes in blood pressure during respiration and from Traube-Hering reflex as contributing to the composition of the normal ICP waveform. Then in the second part we examined the components of the ICP wavelet, which is the percussion, tidal and dicrotic waves. We noted that tidal wave is useful in assessing brain compliance. Then in the third part we looked at the Plateau wave, Lundberg B wave and Lundberg C-wave. The Plateau wave is definitely pathological. Lundberg B wave can occur in both pathological as well as physiological conditions. Lundberg C-wave is physiological, but when it occurs on top of the Lundberg A wave, it heralds terminal event. The important thing about these waves is that the duration is much longer. The most important characteristic of the B wave is its frequency, which is from 0.3 to 3 per minute. The Lundberg B wave is clinically relevant to us when we are trying to interpret ICP recordings from patients with a head injury from normal pressure hydrocephalus, or in whom we suspect the VP shunt is not working. We also need to differentiate between these waves and wave artifacts that could be caused particularly in a awake patient. So I hope this overview of the basics of intracranial pressure waves has been useful to you. Thank you and wishing you a good day. Bye for now.